Good morning, ladies and gentlemen. Uh, Welcome to join us for this live FB. So I'm Dr. Khor, the chest physician in Pantai Hospital. Today is my pleasure to share with you regarding asthma. This is my topic of today, which is asthma overview from children to adult. So World Asthma Day is actually dated on 7 May of 2024. And the theme is Asthma Education Empowers. Information is key. So here is what I would like to do to share as much as information as possible with you. So here is an outline of my presentation, which consists of asthma in Malaysia, definition of asthma, characteristics of asthma, presentation of asthma, treatment of asthma, and what to do if you or your child have asthma, and what is the myth and facts about asthma. So our asthma control in this Malaysia and globally actually is not very well controlled most of the time. From this study done in 2023, for adults, only 34.1% of them are actually well controlled. For children, it's slightly better, up to 54.3%. And many people think that asthma is a mild disease and cannot be fatal, but it's not true. According to our WHO surveys in 2020, there are actually more than 1,000 deaths in Malaysia. So asthma can be fatal. So the natural history of asthma actually varies from person to persons. Most of the time, the onset of the asthma begins in childhood and it may go into remissions. This is most of the natural history of asthma. But about 10 to 20% of them, there's an adult onset of asthma. The causes of it, we are actually not quite sure, but it's actually linked to the genetic component, such as a family history of atopic, which is a form of allergy, or family history of asthma, and environmental factors as well, such as smoking, air pollution, allergy, components such as dust from the air, infections, etc., and etc. So here comes to the next topic, which is definition of asthma. This is from our GINA guideline, which is our guideline to follow in for most of the chest physicians. Asthma is a heterogeneous disease, meaning that it has many phases. Some of them actually severe, some of them less severe, and the presentation may vary according to person, and is usually characterized by airway inflammations. So it is associated with airway hyperresponsiveness, and respiratory symptoms vary over time and in intensity. So what I meant for chronic inflammation is this. When patients have asthma, usually the inner layer of the airways is thickened due to the inflammations. What the inflammations do as compared to the normal airway, the airway will be narrow. There are more secretions in the airway, and in severe form of asthma, actually, the outer layer of the muscles actually will constrict, become more tense, and it will further narrow down the airway. It is usually there's a trigger, such as infections, smoking, air pollution, dust, and so on. So due to the triggers, the asthma will present like cough, breathlessness, chest tightness, or shortness of breath, wheezing. This is one of the examples that show that how many percentage of them actually has these symptoms. This is more of adult patients or children more than 6 years old. For those less than 6 years old, the presentation are more subtle and challenging. They may have only present with cough with no other features or wheezing only. So the diagnosis of asthma usually by clinicians that go through the symptoms, and there is a documentation of variable expiratory airflow limitations. What a physician do is actually they get a good history, then with that, they go on for certain tests or investigations. This is what we call, one of it is a peak expiratory flow. Usually ask the patient to blow to this device, and we counter check whether there is any changes during these past 2 weeks. If there is just more than 20%, we consider it as variable airway. With a compatible history, we can diagnose the patients to have asthma. The other way to do is actually using this spirometry. We ask the patients to blow into it. Then with the computer technology, we can actually generate a graph as well as certain value. So with the graph at the value, we can diagnose patient to have a obstructive airway disease, meaning the airflow of the patients is not well. Then after this, with a compatible history, we can diagnose the patient to have asthma. But things are not as simple because some of the asthma, especially the milder form, usually may not be so straightforward, and the test may be normal. So they need to be put under observations for some time before a diagnosis of asthma can be made. So we need to consider other differentials. This is what I lay out. For example, we need to consider whether it's acute bronchitis, it's an inflammation of the airway, or there is certain component of heart disease, or there's a Walker cord disease as well. So the goals of treatment as a clinician for the asthma actually to achieve a symptom control and risk reductions. Symptom controls means that patient is free of symptoms, there's no wheezing, cough, there's no disturbance of sleep at night, and patients can exercise and can carry out the daily activity without any hindrance from the asthma. And for the risk reductions, the most important thing is actually to prevent exacerbations, which we call an asthmatic attack, a severe form of asthma that can come in a very short period of time or acutely. At the same time, we need to aim to maintain a normal lung functions, prevent death, and minimize the side effect of the medications. So this is the latest guideline for Gina, which is less than 5 years old, 6 to 11 years old, plus those more than 12 years old. So I would like to share this, no matter what guideline at what ages and what stage. Usually stage 1 or step 1 is a milder form of asthma. Stage 4 and 5 is a severe form of asthma. Mild asthma and severe form of asthma. The key message is actually they need a inhaled corticosteroid. Corticosteroid which goes directly to the lungs. You can see that inhaled corticosteroid in a step 2, 5 to 6, 5 or younger. Inhaled corticosteroid from stage 1 to stage 5 for those with 6 to 11, and those with adults more than 12 years old. Here, inhaled corticosteroid. So the main treatment of the asthma actually is inhaled corticosteroids. And I will show this how. So as I mentioned before, this is a normal airway. This is an inflamed airway for mild asthma. When there's a severe asthma, there's a tightening of the smooth muscles, causing further narrowing of the asthma. So what the inhaled corticosteroid is actually act on this inner layer, prevent further inflammations, which is the key pathophysiology of the asthma and the main cause of the asthma. So bronchodilator, our blue inhaler, actually is just act on the act on the smooth muscle, but actually never entertain the inner part of the inflammations. So it may get patient may get a temporary relief from this bronchodilator, but in the long run, it may not actually treat the asthma well, and patient may have go into a further asthmatic attack. So this is just an illustration to show what it is. Inflammation starts actually before patient having symptoms. When patient having symptoms, inflammation also goes up. Then when they start of treatment, symptoms go down, inflammation reduce, but inflammation may persist even there is no symptoms. So that's why this is asthma is a chronic process, may need a long-term inhaled corticosteroids like other chronic illnesses such as hypertension, such as ischemic heart disease, though there is no symptoms. So most, as I mentioned before, only less than 50% of the asthma is well controlled, because most of the time in Malaysia, actually the compliance rate for this medication is rather poor. And in fact, in reality, only less than 5% of them have a severe asthma, which need a regular higher dose and other treatments of medications. So when that's happened, the treatment will be any injectable form of asthma medications. Then we have certain criteria. For example, a component of severe eosinophils during the blood taking is high. So we will need some form of injectable, which is need to be injected 2 to 4 weeks. But most of them, if we control the asthma early with inhaled corticosteroid, only 5% of them actually needs this kind of treatment. So apart from the medications, and asthmatic patients need to avoid triggering factors such as smoking, avoid certain medications that can provoke asthma, such as aspirin, certain painkillers, certain allergens, either indoor and outdoor. And we need to maintain a regular exercise according to our strengths. And we may need to have a healthy diet and maintain a good emotions. So if a patient having an asthma attack, we need to try to keep calm, because emotions or anxiety may actually cause the asthma to get worse. So we may take a reliever prescribed by the patients, usually the blue inhaler every 30 to 60 seconds up to 10 pounds. If a patient is feeling worse at any point, we may need to visit or call an ambulance immediately. If you feel better but you're having an asthma attack, please visit your doctor early as well. So this is some of the questions tends to be asked during my clinic visits. So I have actually laid out 1 to 3 during my presentations. I will go on to 4 to 7 later on. So number 1, asthma symptoms are the same for everyone. As I mentioned, asthma is a heterogeneous disease, so it's not the same not all asthma in children will go away when they are growing up. Asthma can be fatal if not treated properly, and we goes to number 4. So some of the asthma patients like to buy certain medications just to relieve the symptoms. But most of the guidelines say that it is not recommended because simply oral medications, example those that act on the smooth muscle, have a slower onset and a higher risk of side effects, such as the heart may be pumping faster than usual. So this guideline from Malaysia that is not recommended to use oral medications that act on smooth muscle. And these other guidelines to say that it is not recommended as well. So mostly there's one reasons people doesn't like to use inhaler because it's troublesome, it need to be learned. And some of them claim that it's not effective. But most of the time, when as a clinicians, we assess the inhaler technique with things that the inhaler technique is poor. So most of the time, the medications doesn't go to the lungs effectively. So this is one study that showed that poor inhaler techniques leads to poor outcomes in terms of exacerbation, severe asthmatic attack, hospitalizations, and causing morbidity. So this is the blue inhaler, which is the most common used inhaler in Malaysia. So you can see that there are certain steps, and it can up to 50% of them actually not doing correctly. So part of it, yes, we need to learn how to use it, but we can actually learn it quite well after a few of the coaching with most of the patients. So there are 3 types of inhaler in the market, divided into 3 main groups: metered dose inhaler, dry powder form of inhaler, and soft mist inhaler. In Malaysia, the most common one is pressure metered dose inhaler followed by dry powder inhaler. So what we do is actually we need to assess as a clinicians to see which one is correctly used by the patients and which one is the favor of the patients. Then after that, we do the coaching. So if for children, somehow, or for the adults which have a certain difficulty, we may prescribe an aero chamber like these air spaces that's for them to inhale. So as I mentioned, asthma should not be treated when the symptom arise because there is a chronic inflammation of the airway. So the cornerstone of treatment is actually inhaled corticosteroid. So according to this National Review of Asthma that's in 2012 to 2014, is a UK study saying that 46% of the deaths were avoidable if guidelines were followed, meaning that if we use the inhaled corticosteroid early, 77% of those who died were not given asthma action plan, meaning that as a clinician, actually, we are actually not telling patients what's supposed to do when there's an asthmatic attack. 47 prescribing errors, meaning that we are prescribing so much of short-acting beta agonist, the blue inhaler, rather than prescribing an inhaled corticosteroid. So many people think that inhaled corticosteroid has many side effects, but most of them can be avoidable. So the common side effect of inhaled corticosteroid include hoarseness, cough, sore throat, oral thrush, many some infection over the throat, and the children might have a shorter shorter than usual their siblings. But it's actually this is true, but if we are actually have certain steps to avoid it, what we need to do is actually after we are using the inhaled corticosteroid, we just need to rinse the mouth or wash the mouth to wash away all the inhaled steroid that is deposited in the mouth. Then most of the time, the side effect won't happen. And inhaled corticosteroid is not a new medication. It has been there for a long time. So we already know that the strength, what we want to do, what we can prescribe. So if we follow the guideline properly, most of the side effect can be avoided, except that the children may have a broncho may be 1.1 cm lower. But usually I would say that control of the asthma is the top main priority, because sometimes if it is not well controlled, they may have a very bad consequences rather than have a shorter stature than the companion. So many people say that asthma shouldn't exercise because asthma will exacerbate the asthmatic attack. But it's actually not true, because many sportsmen or sportswomen actually is asthmatic patients, but they do well in their field. Just that asthma need to be controlled, and the exercise need to be tailored to one person to another. So my conclusions: number one, not all asthmatic patients will wheeze, and they may have a different presentation in terms of symptoms. Asthma may continue into or reappear in adulthood, especially triggering factors are not well controlled. Asthma can be better. Oral medications, especially short-acting beta-agonist for asthma, should be avoided. So asthma should be treated regularly. Consult the doctor before discontinuing medications. Inhaled corticosteroids are the cornerstone of therapy. Side effects are minimal. Asthmatic people should exercise regularly. Exercise should be tailored according to asthma control. So here is the second part of the sessions, which is questions and answers. So I have a few questions. One of is, what is the most common trigger for asthma? In Malaysia, actually, is smoking. Either it's active smoker or it's a secondhand smoking from the neighborhood or from the people surrounding. Other than that will be the dust and the weather changes, especially there's an extreme of weather changes. Basically hot in the day and extremely cold at night. What is the best treatment for asthma in kids? Actually, for less than 6-year-old, because the kids is growing and the asthma is mild, I'm not need to say that I'm not a pediatrician, meaning that I don't treat asthma for less than 12 years old. But to my knowledge, is actually for those less than 6-year-old, when the asthma is not severe, usually we try to treat with the blue inhaler, which is short-acting beta-agonist. For the adult, or for those in more than 6-year-old, when the asthma is more severe, inhaled corticosteroid is the main treatment, with bronchodilator as an adjunctive or at the end on therapy. So how can you prevent or lessen the effect of asthma? The question, to lessen or prevent the asthma, actually we need to have a well-controlled asthma. So well-controlled asthma actually come into threes. One is try to avoid the triggering factors. And some of them is vary from person to person. Some of them actually very allergic to dust, so you try to avoid that. Some are allergic to smoking, so you try to avoid that. Second thing is you need to have a good inhaled corticosteroid and you need to have a good technique of how to use it. Thirdly, when you are talking about prevention or lesson of asthma, you are actually need to actually go on to exercise regularly. Actually, asthma is a disease of airway. When you are actually exercise regularly, you will improve your lung functions. Does asthma go away? This is fourth questions. Asthma, the chronic inflammation will be there, but asthma symptoms can be well controlled if you use the exercise regularly and follow the instruction of the doctor. And you use the medications as instructed by the doctor as well. It will go into remissions, meaning that you can lead on to the normal activity of your life. But it may comes back when there's a triggering factors. But most of my asthmatic patient actually, when actually it's well controlled, actually there is not much of the problem. Can my asthmatic child engage in physical activity? The answer is yes. So especially children, the lungs is not actually grow. The lungs is still growing. So you need to have a good regular exercise. But exercise need to tailor to the asthmatic control, need to tailor to the one physical and the strength of the uh, body. Meaning that you can't ask a patient or asthmatic patients who is not actually regularly exercise to go for swimming every day. So you need to ask them to have a schedule exercise. For example, you ask them by start walking faster than usual. Then after for a while, you ask them to actually start jogging before you go to swimming, etc., etc. This is kind of a program exercise for them. So number 6, can inhalers affect my children growth and development? So the inhaler, it actually depends on what kind of inhaler. So those with only blue inhaler, usually it won't affect the growth. But those with inhaled corticosteroid, there are some studies say that the bone growth might be shorter, which is about 1 cm on average. Are traditional remedy useful in elevating asthma symptoms? As far as I know, the asthma, it may not, I would say. Some studies say that honey may actually useful in asthmatic controls, but it's rather a controversial issue that we don't have as robust evidence as our inhaled corticosteroids. How can I reduce asthma triggers at home? So I think most of the time, the environment that causing asthma is actually come from trees. One is smoking. See whether there's a smoking in the house, or we should actually ask the surrounding people to stop smoking if possible. The other thing is from dust and pollen. Usually this come from the carpet. So usually I don't encourage people to have carpet in the house. Second, third one will be pets, cats, dogs. The fur might trigger the asthma. The mite or other bacteria might trigger the asthma. Are there any difference in treatment method used for children's asthma and adult asthma? So for those with less than 6-year-old mild asthma for children, usually the bone growth is rather important. So usually, if possible, we may need to try to avoid inhaled corticosteroid. But come when a more severe form, of asthma, we have no choice but to start using inhaled corticosteroid. Other than that, there is no much of difference. So the treatment, the cornerstone is still inhaled corticosteroid for most of the time. I think that's all for question and answer sessions. Okay, I think that's it. Thank you for joining us. That's it.